Dr. Lauren Silverman is our Stephen Camp lecture presenter today. Dr. Silverman is the director of the Division of Pediatric Endocrinology at Goreev Children's Hospital in New Jersey. He attended Columbia University as an undergrad and attended medical school at Rutgers Robert Wood Johnson Medical School. He completed residency at Long Island Jewish Medical Center, Snyder Children's Hospital, followed by a fellowship at CSF, where he was mentored by highly acclaimed and internationally recognized pediatric endocrinologists, including Dr. Mel Grumbach, Selna Kaplan, and Felix Conti. Over the past 30 years, in addition to clinical practice, Dr. Silverman has been involved in resident and student education, as well as clinical research. His research pursuits have focused on clinical trials in the areas of growth and puberty. He monitored for the OPKO long-acting hormone trial. He has over 25 publications related to these pursuits. Additionally, he has served in various committees in both the PES and Endocrine Society. A product of the Jersey Shore, he routinely attends Camp Neheda, the New Jersey camp for children with diabetes, and is proud to be a champion for diabetes in the annual Tour de Cure bike ride. Dr. Silverman is our Stephen Camp lecturer today. Dr. Stephen Camp was a board-certified pediatric endocrinologist from Arkansas. He made a significant contribution to pediatric endocrinology in the area of growth disorders, and medical ethics. He was a mentor to many students and pediatric endocrine fellows. He was an active organizer of Pestola. So we are honored to have Dr. Silverman present the Dr. Stephen Camp lecture today, titled Longer Acting GnRH Agonists, Long-Term Outcomes. Thank you very much, Dr. Silverman.
Thank you, Susan, for that kind introduction. And in New Jersey, we say Camp Neheda. I realize in Texas, you say Camp Neheda. You know, I had some ice on the trees this morning, and unfortunately, due to travel restrictions from work, which were lifted on Monday, COVID said I couldn't travel. But given the ice, I'm not sure I would have gotten there. I am going to try and, oh, I did something wrong already. Hold on. I'm going to try and share my screen. And please let me know if we're okay, or let me know if we're not okay. So these are my disclosures. So I
are not seeing your screen yet, sir.
Excuse me?
We are not seeing your screen yet.
Okay, hold on.
Maybe when you went to share screen, you selected the wrong one. So try exiting shared screen and going back to it. Okay, you see your desktop?
There we have it now.
There we go. And now we see it.
Perfect. Okay, so that's me and our emblem. Those are my disclosures. So I knew Steve a bit. We actually were co-authors on a D&T publication about growth hormone. And since I'm speaking about puberty, I figured I would try and figure out if he wrote anything on puberty. And this was a response to the Herman Gennens article that appeared in Atlantis. And our previous speaker also wrote a response to that article. Interestingly, we can play pediatric endocrine geography, but my son, who's a first-year medical student, is a chef or has worked in restaurants significantly and has a master's in ethics. I can't say that I've composed any music, but I used to play. So what is puberty? Puberty is a transition from an immature hypothalamic pituitary gonadal axis into an adult axis that's capable of reproduction. It's also a time of significant psychosocial change. And when is puberty? And this is a time cover from 2000, it's been updated, but in 400 BC, Aristotle felt that puberty occurred when twice 7 years old. In most cases, male begins to engender seed, and then at the same time in the female, breasts swell. So what we're going to talk about is early or precocious puberty. But I think, as pediatricians first and scientists second, we have to think of the big picture. So as endocrinologists, we know that puberty, is a continuum from the mini puberty of the fetus and infant, which is important when we evaluate kids for DSDs in the nursery, then the juvenile pause. And I like to teach that it's a reactivation of the hypothalamic pituitary gonadal axis. And having been trained by the folks at UCSF, it is gonadotropin-dependent sexual precocity. And I think if we teach our residents and students and fellows to think that way, dependent versus independent, it really helps them approach a differential diagnosis. Obviously, this has morphed into central precocious puberty, but if we use that term on rounds, we would not be well looked upon. And again, it's a reactivation of, actually, that's a mistype. I apologize. It's the HPG axis. And there is an endogenous pulsatility to the GnRH neurons, as you can see here. This is, in a model, and this is shown to occur in the Petri dish with the GT1 cell line. Every, 40 to 60 to 80 minutes, we are seeing pulses that leads to LH and FSH release from the pituitary, and ultimately the downstream sex steroid effect. And this is really a very important paper from the late 70s from Tony Plant's group in Pittsburgh, and I believe it's on the PES history timeline. And what he did was he placed a catheter into the lateral ventricle of a rhesus monkey, and he infused LHRH at the time, luteinizing releasing hormone, or GnRH, in a pulsatile fashion. And he showed that he got pulses of LH and FSH. If he then gave it in a persistent fashion, then the LH and FSH pulse generation shut down. But if you gave it back in pulses, it would resume. And that's actually the basis of our therapy. So long-acting GnRH agonists shut down the pituitary response to the GnRH pulse generator. Ultimately, clinically, we see a diminishing growth acceleration and advancement, a reversal or a lack of progression of clinical signs of puberty. We can theoretically hold bone age advancement, and we may increase the final height in these children if they're treated in early enough age. And we know that biochemical puberty resumes when treatment is discontinued. So when we talk about the GnRH agonist, we need to look at the structure of native GnRH or native LHRH. So it's a decapeptyl, right? So it's a 10 amino acid protein. The first 3 amino acids are important for activation of the receptor. Then we have regulation of a receptor affinity at 5 and 6, and 6 is circled. And then we have regulation of biologic activity at the N-terminal end. And if we look at the relative potency of native GnRH all the way through decapeptyl and other agents that have been developed, we see that the potency increases based on what the substitution is at amino acid 6 and what the N-terminal agent is. When we think about therapy for these kids, we need to think about what makes sense. So it has to be obviously done in an outpatient mode of administration. It's got to work, but it also has to be reversible. So if you think about perhaps the main group of patients treated with GnRH agonists, men with prostate cancer, you're truly not worried about reversibility. Obviously, when you're talking about fertility treatments and women with endometriosis, reversibility is quite important. And obviously, it has to be safe. So these are the current medications available in the United States, and this is out of a publication that I'm an author on, that it's it is presently in submission and revision. So we've got the various leuprolides under brand name Lupron, 1 month, 3 month. We've got the triptorelin under brand name Triptidor, which is 6-month duration, a subcutaneous leuprolide, brand name Fensolvi, and then the Suprelin implant. And again, thinking about the potency, Historelin is actually the most potent, and leuprolide is actually the least potent of what we have available. Intranasal Cinerel and daily subcutaneous leuprolide are still available. And having done this for a bit, the first patients I took care of were we called the medication they were on historically D-TRP6, which was leuprolide. So I've used all of these. And just so people can understand the difference between the depots, so the classic Lupron depot or Triptidor is actually a lipid nanosphere, where the medication is both on the outside of the nanosphere as well as embedded within the nanosphere. So it's released over time. Fensolvi is actually a compound that polymerizes once it's been injected subcutaneously, and that's how you get the delayed release. And obviously we know that the Suprelin is the Historelin implant. So this is actually the first patient that was treated in Boston by Bill Crowley. And if you ask Bill what their approach was, they said, well, as soon as they saw that this medication was available for adults, and the fact that previous to having GnRH agonist available for therapy, all we actually had was progesterone treatment, or medroxyprogesterone acetate, it was sort of a no-brainer to give this a try. And as you can see, the first child treated was a 2-year-old with precocious puberty, gonadotropin-dependent sexual precocity. Even I fall into the CPP trap. And this paper is from 1981. This is her pre-therapy LH pulsing, LH and FSH pulsing at night and day. And this is her response to a leuprolide stimulation test, native GnRH or Factrel. And then on therapy for 8 weeks, you can see that the pulsatility shut down and she had a flat stimulation test. And then most importantly, off therapy, things resumed. And this was followed by the group at the NIH in concert with the group in Boston, the group at UCSF, doing longer term studies on these young kids, mostly girls, as it's female predominant. And again, we see that with daily leuprolide, this is just this is 5 patients, positive leuprolide stimulation tests, flat stim tests on therapy, and then post-therapeutic resumption. And this was the subsequent paper in the New England Journal, also in 1981. This is the NIH group. Subsequently, and this actually came out, was under study when I was a fellow, there was the development of the quote monthly, which is 28-day depot leuprolide. And actually this study was 30 days treatment. And what we see in the solid lines is the results of GnRH tests. So you have a markedly elevated LH and FSH. But on treatment, after 30 days, the LH and FSH stayed flat. And this was 1989. And so again, the first of the longer acting depots was shown to be efficacious in 89. And this had an N of 5 in that original study. And there were no treatment failures in that original therapeutic group. The next thing that came out historically was the Historelin implant. And our group and I was very involved in the trial. And these are actually all the various results of all the kids in the original trial, both naive and non-naive. And we used a cutoff of a peak LH of 4 at 1 month of age as a proof of efficacy and for FDA approval. And you can see that all of the patients did suppress, and they maintained suppression through 12 months of age. And there were no treatment failures in that group. Subsequently, the 12-week leuprolide depot IM trial was undertaken. Karen Klein has been intimately involved in all of these injectable depot studies as well. And in the original trial, there were two doses, 11.25 and 30. We talked about the middle dose, which was what was available in the adult population, but the agency and the pharmaceutical company and TAP at the time decided these were the doses that they would want to use. And you can see that you actually had fairly good suppression of LH in regards to peak stimulated LH. Basal LHs were occasionally elevated. And Dr. Thornton, who I assume is in the audience, when I went back and looked at the original report from Dr. Crowley, they specifically noted that a basal LH is not something to judge a lack of suppression by. And Paul will know that we published that data from the Hystrelin study. Erica Oikster published the same data. So when you are looking at efficacy of treatment, you can't say that a basal LH of 2 or 3 means you're not suppressed. However, there were treatment failures in this group, 9 treatment failures in the low dose, 2 treatment failures in the high dose. They were naive patients, but more importantly, no non-naive patients escaped suppression. And I believe most, I can't say all of us, and certainly our group, when we do treat with the 12-week, which is 84 days, Lupron, we're using the 30 milligram dose. The triptorelin pivotal trial. So again, this is the 6-month or 24-week injectable triptorelin. Did show 95% suppressed at 1 month, 93 maintained suppression at 6 months. So 3 of the total 44 patients did not maintain suppression of LH. 2 of those, however, were males. And we do know that boys with gonadotropin-dependent precocity are occasionally a different group. We also know that the very young patients can be a different group, and certainly patients with underlying anatomic issues, specifically hamartomas, may also be more difficult to suppress. And finally, the newest player on the block, which is the subcutaneous triptorelin, or the Fensolvi, and that was published, I guess, 2 years ago at this point. And again, Karen Klein was one of the leads on the study. There were 9 patients who didn't suppress LH at 12 weeks, 8 who didn't suppress at 24 weeks. But more importantly, and those are peak LHs, more importantly, only 1 didn't suppress estradiol at 12 weeks and 2 did not suppress at 24 weeks. And I think everybody is developing an experience with all of these longer acting injectables, as well as the historical experience with the 28-day Lupron and the implant. And I think we're all being pushed by our formularies of what we can or cannot choose to use. There are some practical issues about using them. The Triptidor injection needs to be given very quickly because of the mechanism of action. It can actually become much more difficult to inject unless the injection is given promptly after mixing. The Fensolvi also needs to be mixed well, and the injection has to be given deeply. It's sub-Q, but it has to be all the way in. And then finally, we do know there are multiple case reports, including some from us, of broken Suprelin implants that maintain suppression. And I just saw a case report of an implant that was in for 5 years that was still working. We had a patient who was in for 3 years. So again, there are always the real world experience of using all of these medications. And part of it is obviously because puberty is indeed the wonder years, both for us as parents and more importantly, as clinicians. Okay. So again, what happens when the medication is discontinued? That's obviously quite important, alluding to some of the things that Sharon was talking about in the last talk as well. So again, going back to the original presentation, the original data from the NIH group, this graphic is strikingly the same as the one I showed you of what happened in the rhesus monkeys, right? So pre-therapy, you have an endogenous pulse generator, okay? On therapy, the endogenous pulse generator is shut down. Off therapy, the endogenous pulse generator is reactivated. And obviously that's extremely important. And looking at the recovery of the axis, and I like to teach the residents that literally the first paper that was written showed that it worked. And the second paper, and this is 1988, out of the NIH Boston Consortium, showed that when the medication was discontinued, things turned back on again. So again, this is your pre-therapy peak, LH and estradiol. This is at the end of therapy, so the last visit to the CRCs when patients were on meds, estradiol was shut down, LH was shut down, testosterone in the boys. And then by 3 months, you saw normal peak stimulated LH, and certainly out to 12 months of age, 12 months post-treatment. Kirk Neely, it's amazing. There was a nurse at AbbVie, TAPT and AbbVie, who somehow kept this original Lupron study going in the out years. And a lot of this data was published in the 2010, 2010s. I was asked to sign a 1572 about, 15 years ago for my involvement in the study in 1990 as a fellow. There were no 1572s in 1990. But we can see that when the kids, when Lupron was discontinued by 6 months of age, their mean peak LH was up to 21, similar to their pre-treatment LH. And we'll get to some of the other recovery data as we go on. But again, this is sort of a real world experience in a larger group of patients. The Japanese group looked at menarche in girls who were treated with Lupron. And the solid line is the girls who had menarche before treatment. And we see that 50% of those girls had their first recurrent cycle after treatment at about 10 to 12 months after the treatment was discontinued. And the girls who never had menarche in the first place, that 50% was somewhere between 15 and 20 months. So somewhere in that 1.5 year mark is when you would expect the girls to resume their menses. If we look at the recovery of the axis in the kids treated with the Kestrelin implant, similarly, we see that, this is, the original group of patients in the study was 35. And, ultimately only 2 of them were treated for 6 years. But when we looked at all of the kids after, when they came back after the implant was removed, and unfortunately only 8 of those kids followed up in the study, by 6 months, we see that they all had positive pubertal stimulation tests. And similarly, we see that their estradiol levels were recovering as well. Thinking about menarche, again, the group in Israel who was involved with the original Suprelin implant trial looked at the time to menarche in kids who got triptorelin, which is what's used to treat in Europe, even a number of years ago, versus the implant. And you can see that it took a longer time to menarche in the kids who had injectable versus the implant. But if you think about it, that probably makes a lot of sense, because you have an injectable medication that needs to wear off over time. There's still some medication that's there. However, once the implant is completely removed, as I alluded to earlier, it's gone and the medication is gone. So it's literally just the half-life of the historelin. And again, historelin is a much more potent agonist, but it does not seem to be interfering with any of the recovery, even though it is more potent, because it's reversible. Last year, a very important study was published from the group in Europe. It's called the PREFER study, and I would refer you to it. It's in the journal of our society. It's in Hormone Research in Pediatrics, which you all should have free access to as members of the society. And I'd ask you to look at the solid bars. It's the full analysis set. But the question asked was, in those women who chose to attempt to attain pregnancy, were they able to attain pregnancy within X amount of time, having been treated for sexual precocity as young girls? And the answer was that 90% of women were able to achieve pregnancy. And that's extremely important. You know, I was taught, I guess perhaps not correctly, that the natural infertility rate is closer to 20%. In this cohort control in the European countries that were used, they quoted a natural infertility rate of about 10%. And that's what was seen in this group of women. So there does not appear to be any difference in fertility outcomes in women who were treated for sexual precocity as children versus their peer-matched population. Right. Other things that we are always concerned about is body composition. So what this is looking at in an outcome study is looking at the bone mineral density adjusted for chronologic age at the top and bone age at the bottom after treatment with GnRH agonist. So please remember that these kids have been exposed to sex hormones, therefore their bone mineral density is likely to be quite high for chronologic age at the start of therapy. It may or may not be appropriate for bone age. So we have to look, even though there may be less accretion of bone mineral density over time, we have to look at the out years. And if we look at the out years, you know, at the discontinuation of therapy, the bone mineral density in black was at the mean. 1 year after the end of therapy, it was also at the mean. 2 years post therapy, it was, you know, minimally above the mean. And again, we're seeing an improvement or a normalization, not even an improvement, for a bone age ST score as opposed to a chronologic age ST score. But even so, these are all within 1 SD of the mean. So they all are quote unquote normal. Similarly, the question has always been asked about body composition. Well, when you think about what we're doing in these kids is we're changing their growth dynamics, right? So these kids have had growth acceleration. They've had increased growth hormone production due to the synergy of sex hormones. And therefore, the prepubertal chubbiness that, you know, we certainly see clinically all the time has disappeared. And you may therefore say, well, when they start therapy, they're gaining body fat. Well, again, we have to think about how it's changing for bone age, how it's changing for pubertal status, not just how it's changing for chronologic age. So I just ask you to look at the black and the white. So the black is the lean body mass and the white is the BMI. We'll get to the height later, I promise. So at the start of therapy, their lean body mass is relatively high for chronologic age. Again, this is not for bone age. And at the discontinuation of therapy, their lean body mass may drop a little bit, and there's a trend towards an increase in BMI, but it's not statistically significant. When we go out at 1 year and then 2 years after stopping therapy, their lean body mass is normalizing. In fact, you can say that it's dropping, and their BMI is also tending to normalize and drop from the suggestion of an elevated BMI that we saw at 1 month of therapy. I'm sorry, at the end of therapy. So what about height? So, you know, this has always been one of the reasons that we are treating kids with early puberty. You know, in my mind as a pediatrician, you know, the psychosocial aspects are more important than the height aspects. However, the real world of who walks into the office, you know, even the 11 and 12-year-olds are asking about the fact that their in puberty isn't going to affect their height. Can't we play with their puberty to, quote, improve, unquote, their height? So we see, obviously, as we're all aware, and again, this is from the original cohort in the late 80s from NIH in Boston, that pre-therapy, these kids had, you know, advanced bone age to chronologic age. Therefore, their predicted height was low. Obviously, they had an elevated growth rate. They had a high growth velocity. Subsequently, at the end of therapy, as we would expect, the growth velocity dropped. Their predicted height increased because we were able to change the delta bone age over delta chronologic age, right? If that's going to less than 1, you're quote improving unquote height projection. I don't predict height, I project height. Okay. That appeared to hold at 3 months out with a predicted height, and it held at 12 months out. Again, where do the predicted heights wind up versus, in regards to your final adult height? So this is the outcome of that TAP trial. Again, Peter Lee and Kirk Neely and Katie, whose last name I don't remember, who was the nurse at TAP, kept this going forever. So this group had a target height of 164 centimeters at the initiation of treatment, and you can see the N is 29. And at the baseline of treatment, their height prediction was 157. At the end of treatment, 18 of them had a predicted height of 166, so it surpassed their target height. And the final adult height that was reported, it was not measured, actually matched their target height. So again, this is an original group of 50 patients, 49 patients. Their mean age was 7. Their bone age advancement was 3 years. They were tall, but they did actually get to their target height range. If you get within minus 0.6 SDs of your parents' heights, you're doing great. And again, this is another way of looking at it. Their height SD score was plus 1.8 at the beginning of treatment, 0.8 at the end of treatment, and got to minus 0.06, excuse me, at adult final heights. So one would say that for this group of kids with a mean age of 7 and a bone age advanced 3 years, that we did positively affect their final adult height. Standing height, deference to Alan Rogel. All right. Similarly, looking at the kids with the Hysterel and long-term follow-up, and they were followed out to 5 years, but unfortunately, there was a relatively small number of kids who got out to that time in treatment. But we can see that their bone age over chronologic age decreased over time. Here's the ratio, and their predicted adult height increased over time. Unfortunately, we were unable to keep this study going to collect their final adult heights. But certainly in this, again, well-defined group of kids who met classic criteria, meaning pubertal changes before the age of 8, a bone age, girls before the age of 8, a bone age advanced by at least 1 year, we absolutely increased their predicted heights through therapy from a mean predicted height of just over 150 centimeters to one closer to 165. So when I was a fellow, went back, and Dave Paul, who is in Texas, I'm not sure if he's at the meeting, hi Dave if you are, went and looked at the patients who were treated by the UCSF group and compared them to the historically treated girls who were treated with medroxyprogesterone acetate, who were treated with Provera. And the conclusion that the UCSF group came to was that we definitely improved the height of kids who are treated at less than 6 years of age. It's not clear that we improved the height of kids who are treated at over 6 years of age. That has not persisted in all studies, but this data here, again, is suggesting that in treated kids versus untreated kids, if you're treating at a young age, you're improving their height outcome. If you're treating at an older age, you may not. And again, if you sort of look at the scattergram of the age of enrollment and the kids' heights, there certainly is a trend to a taller adult height outcome in the kids who are treated at a younger age. And obviously the duration of treatment also affects your height outcome. But and again, this is the French data, which didn't suggest it. So this is Carrel's data, and this is the NIH data. But I think the problem with that is that the duration of treatment is a surrogate for your age at presentation and likely how advanced your bone age is. So this certainly follows, right? If you've got a 4-year-old with a bone age of 10, obviously she's going to be treated for a really long time, as opposed to a 7-year-old with a bone age of 9, who you may only treat for a year or two, get it so that, she can be in 5th grade or 6th when she has her first cycle. And then this is a study that I found recently that's about 2 years old, looking specifically at boys with gonadotropin-dependent sexual precocity. And again, in black is their predicted adult height, in white is their target height, and then the hash mark here is their final adult height. So these are 20 kids who were treated over time. And we can see they started with a height prediction of 170, slightly less than their mid-parental target height. At the end of treatment, their predicted height was 174, again, greater than their target height. And their final adult height did reach their mid-parental target height. So that certainly is a positive outcome. And there's a meta-analysis that was published last year. And again, I would just sort of have you look over towards the favoring. And we see that the mean difference is tending towards favoring treatment in regards to improving adult height.
Dr. Silverman, I'm so sorry. If you can wrap up.
Yeah, I'm there. Okay.
We're running out of time.
All right.
Thank you.
So I gave you the past, I've given you the present, and what about the future? So this is just a question. So it's not an off-label use. We are using GnRH agonists. They downregulate the receptor. There is a pituitary desensitization after initial flare-up, and there is slow reversibility. The adult world is using GnRH antagonists. They block the receptor without receptor activation. They competitively inhibit. They're immediate and they're rapidly reversible. So my first talk in medical school in 1983 by the dean was about AIDS. HIV had not been discovered or described yet. This is your syphilis. This is how you are going to learn medicine. I'm sitting in my basement, 700 yards from the first containment zone in New York of the first COVID outbreak. There is no evidence that COVID vaccine affects puberty. However, we have all seen deferred care, and we have all seen the explosion of obesity. So I think we are likely having an ascertainment bias and seeing some kids with a bit late picked up or some rapid progression in puberty because of the weight pushing it.